All right, I think we're going to get started. Hello, everyone. Thank you for joining us today. My name is Susannah Baruch, and I'm the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. Welcome to our webinar, Aligning Criminal Practice with Addiction Science. Just to go over a few logistics notes before I introduce our speakers. As you'll see, you can submit questions using the Q&A feature in the meeting controls that are at the bottom of your screen. You can also join the conversation on Twitter at Petrie-Flom. We will share the fully captioned event video with everyone who registered within a few weeks. If at any time during this webinar you have technical issues, please email us at petrieflom@law.harvard.edu and we will try to help. And finally, if you're interested in other upcoming events, news, or other programming, please check us out online, sign up for our newsletter, read our blog, The Bill of Health, and listen to our new podcast, Petri Dishes. Today's webinar focuses on the way our legal responses to substance use disorders get the neuroscience and the research wrong. We are thrilled to feature two brilliant experts who've received national attention for their legal work in this area. And this event is really the brainchild of my colleague, Stephanie Tabashneck. So I'm going to introduce her and then let her take it away. Stephanie is a forensic psychologist and attorney who is a senior fellow in law and applied neuroscience with us at the Petrie-Flom Center at Harvard Law School and with our excellent colleagues at the Center for Law, Brain, and Behavior at Massachusetts General Hospital at Harvard Medical School, where she is leading the effort to create the first Harvard-affiliated neurolaw library, which will provide resources for all of us. You can and should read all about her at stephanietabashneck.com, but with that, I'm going to turn it over to Stephanie to get us started in the discussion.
Thank you so much for that wonderful introduction. So I'm going to be talking about the neuroscience and science of substance use disorder and addiction, and then I'm going to kick this over to attorney Lisa Newman-Polk and do a more thorough introduction of her. So let's see, let me just pull up my screen. Okay, there we go. Can everyone see my PowerPoint? Are we good? Great. So during the pandemic, we saw a extreme increase in the rates of addiction and substance use disorder. And when we think about the conditions that really breed substance use disorder, isolation, social stress, employment stress, boredom, these were all in full force during the pandemic. And so we're seeing even more people than usual in the criminal justice system who are presenting with addictions. And Lisa's going to talk a little bit more about that. So before I launch it, I just want to talk about racial disparities in drug enforcement and sort of who is seen as a criminal, quote unquote, and who is seen as a patient, quote unquote. And what we know is that Black and Latino individuals are more likely to face negative outcomes at every stage of the criminal justice system, from just being stopped to even what sentences that they receive for the exact same behaviors. And we see disparate enforcement of drug laws, and we also see disparate access to quality treatment and harm reduction. And there's a lot of racism sort of built into our existing system. So I want to debunk some myths right off the bat, because I think they're really important. And sometimes we say at the Center for Law, Brain, and Behavior that the courts are about 20 years behind the science. I think with addiction, they're probably like 40 years behind the science. But here are some myths that I'm just going to briefly go over. So one myth is that all people who use drugs are addicted. So most people who use substances are not addicted. And someone who uses, say, cocaine a few times a year, that would not be an addiction. I have clients who previously had pretty severe substance use disorders that have now been in recovery for many years, but may at some points, a few times a year, still use, whether it's heroin or alcohol or whatnot. They would no longer meet criteria for a substance use disorder or addiction. People addicted to drugs use drugs to get high. This is another myth, and I'm going to talk about the neuroscientific basis for why this is a myth in a little bit. People who use drugs can quit whenever they want, or people need to hit rock bottom to get treatment. So what we know is that for some people, rock bottom is death. So we don't want people waiting until rock bottom. And we know that quitting drug use can be really, really hard. We also know that people do not need to want treatment for it to work, and people don't need to abstain from drug use to get treatment. So, for example, in my clinical practice, my therapy practice, I see people who have had substance use disorders. And most, when they come in to work with me, they say, hey, I really want to just cut back. I think I'm using too much. And the very first step that we do is seeing if moderation works. So, for example, instead of using 7 days a week, can they use 4 days a week or 3 days a week? Or instead of using for 3 hours a day, can they use for 1 hour a day? These are the things that we're doing to try and help people to get control over their drug use. And most people can actually moderate their drug or alcohol use to the extent that they no longer qualify for a substance use disorder. Now, other people, they can't do that, and they really need to abstain from drugs and alcohol, but still, even if they are abstaining, they're likely to have some periods where they're still using. And for instance, I have a client who every 3 months will drink a bottle of wine, and that's sort of what happens. And then she, the next day, she stops drinking, and things are sort of, that's a good outcome in my field. Interventions are the best method to get a person into treatment. This is a myth that I think was popularized by Dr. Phil. What we know is that interventions, especially interventions that threaten withdrawal of support, have a higher risk of overdose. So we want to sort of avoid those. Another myth is that treatment only needs to happen once. This we see a lot in criminal and family court, where people sort of the expectation is, wow, you went to a 30-day program and you relapsed 1 day after you were released. What happened? And yet, relapsing within the first day or week is a very common outcome. And most people need 4 to 5 iterations of treatment before it sticks. But that said, most people never get treatment, and still over the course of this illness, they enter into sustained recovery. So people who are addicted to drugs are bad, weak people. It's a personal moral failure. These are other myths. And I would say that some of the best people that I know are in recovery, and every day are fighting to make up for some of the mistakes that they made while they were in the throes of addiction. So these are really important. And another, I would say, myth that plays out a lot in criminal court is this idea that it's only progress if the person is abstinent. And this can be really frustrating for me as a clinician when I have a client who is working so hard and making such progress. I have a client with alcohol use disorder, and he, for the past 365 days, he's probably used 10 days. So for 355 days, he's been completely sober, yet he's really judged in criminal court by these 10 days or maybe 30 hours that he has used substances. So we really want to be mindful of whether the clinical goals and the clinical best practices are matching up with the expectations that we're imposing, especially with, Lisa will talk a little bit more about probation conditions and things like that. So other goals that are really important when you have a substance use disorder is decreasing use, having safer use, transparency. So with my clients, I really encourage them to let me know if they've had a slip up or a relapse. And this can be really tricky if they're engaged in criminal court and they're told that they need to disclose if they have a relapse, but they know if they have a relapse that they're going to be potentially thrown in jail. So I had a client who spent most of the summer in jail after he drank alcohol 1 day. So it can be extremely punitive and not map onto clinical best practices. So just something that may be surprising to you here is that the most addictive drug from first use is not heroin or methamphetamines or alcohol or cannabis. It's actually nicotine. So for most people, even if they're using a drug that's really addictive like heroin, they're not becoming addicted after first use. So it does not mean that I'm encouraging people here to go out and use these substances, but I do think that's relatively interesting. So what causes a substance use disorder? This is really a mix of genetics, adverse childhood experiences, so abuse, neglect, trauma, and then early use. And for those of us who work in the criminal justice system, it's not uncommon for us to hear from clients that the first time they drank alcohol was with their parent and they were like 6 or 7 years old. So when you combine these things, you really create risk factors for future addiction. And genetically, you can think about genetics, which makes up about 50% of the risk. Even things like how good alcohol tastes, or, for those of you who've ever had a serious surgery and were prescribed a medication like Vicodin or Oxycontin or Percocet. And for many of us, we take that medication and it doesn't really profoundly affect us. We don't become addicted to it and we're fine. But how that drug even impacts the receptors in our brain is really driven by genetics. So some people, they use those medications, 2 or 3 times, and they've developed really risk factors for addiction, and they've quickly become addicted to the substance. So even things like risk taking are heavily genetically dependent. So how much risk someone's wants, how much alcohol or drugs makes us feel good, those are all genetically dependent. So, and I'm sorry for this really creepy picture, but there's been really interesting research on looking at fetal brain scans in animal models. And what they found is that in the fetal brain scans that reflected low dopamine D2 receptors in the striatum, a region of the brain, that when after birth, these individuals were far more likely to develop a substance use disorder later on. So you can essentially predict, just based on low dopamine in the striatum, who is much more likely to have a vulnerability to developing a future addiction. So what actually happens to the brain when you when you're exposed to an addictive substance? So for example, if we're thinking about opioids, what happens is, so you inject heroin, your brain, say it's the first time you're injecting heroin, your brain is flooded with dopamine, okay? And in the early stages of using the substance, you're going to experience a lot of euphoria and pleasure, okay? But what happens next is the brain says, this doesn't make sense. Why is there so much dopamine? Never in evolutionary history has there been this much dopamine in the brain. And what the brain does is then it downregulates or decreases dopamine receptors. And what's notable about this is that dopamine is something that helps us feel good, and it's also a teaching tool. So when we use the substance, we feel good. And the teaching tool is that it basically says, hey, you should do this again, okay? And addiction lives in the region of the brain where your will to survive lives. So if you think about, for many of you, you're doing some holiday partying or holiday dinners, and, it's like not eating for 5 days and then sitting down to a beautiful spread of food and being told that you can't eat. So you have this will, you have this drive, but you can't eat because it's bad for you. So it's like basically, the cravings that you experience around substance use disorders are very similar to other cravings that are consistent with survival, like the will to have food. So substance use disorder, the use of substances, it creates really powerful cravings, and also makes you less receptive to other pleasures in life. So for people who are parents, if you have a child and you're picking them up from school and they're bounding, say they're 5 and they're bounding after you and they give you a big hug, your brain is not going to be firing in the same way if you have a substance use disorder. So even the things that incentivize attachment and caregiving and those rewards are sort of no longer present. And it's really challenging, and people feel very bad. So they feel very depressed, and the only thing that makes them feel better is unfortunately, the substance. And this is just a chart or a image showing that what the brain looks like when there is heroin used. So what you're seeing is the brain is flooded with dopamine, and there's a decrease of GABA. So GABA inhibits dopamine, and then what happens is the brain is flooded with dopamine, which makes the person feel good initially. So in daily life, we have a fluctuation in dopamine. We're not just all going around with the same amount of dopamine. So if we say the baseline is 100%, say you have I don't know, your favorite food, whether it's fries or chocolate or, we're in Massachusetts, so Dunkin' Donuts coffee, 100, and your brain might spike to 150 or 200, but it'll go back to 100. Okay, so you're feeling like some variability. Now with people who have a substance use disorder, their dopamine levels are already low, so they're feeling bad, and the substance use increases their dopamine. So say they're at an 80, and they use cocaine, so they go up to 400. Okay, so then they go down to a 70 because the brain says, oh, that's too much dopamine. And then the next time they may go up to 100 or 200. And over time, their baseline is going to be shifting, and it's going to shift down to, a 70, 60, 50, 40. And, as Dr. Rupodi says, that level of dopamine is really inconsistent with survival. And you're not able to really do well getting out of bed, holding down a job. You're just feeling really terrible all the time. You're feeling really like horrible physical symptoms. And the only thing that makes you feel better is using the substance. And unfortunately, the substance is no longer giving that same high, but it is helping them feel some relief. And a lot of people who use substances or are addicted to a substance say that they feel more like themselves when they're using the substance. And part of that is because of their dopamine is temporarily increasing to a level that is more similar to what their baseline had been with dopamine. So it might bring them up to an 80 or a 90, which is where they used to exist. So, if you don't sort of buy this and say, oh, Stephanie, I don't know if you're telling the truth about this, here are some brain scans. And this is looking at on the right. And so on the left, we have the control brain. Okay. And what you want is a lot of red and orange because the signals depicts dopamine D2 receptor availability. So we have the control brains on the left. So we have 4 different control brains. So that's the non-addicted brain. And on the right, we have 4 different brain scans of cocaine addiction, meth addiction, alcohol addiction, and then heroin addiction, okay? And what you see is there's very little red or orange or even yellow on the brains on the right, as compared to the control brains, the non-addicted brains on the left. Now, what's really interesting is when you look at the alcohol brain scan, you do see some red and orange. And this is the neuroscientific basis for the term functioning alcoholic. And I don't use that term, clinically, but basically people who have an alcohol use disorder often are able to go about their lives and hold down a job and engage with friends and parent. They may be feeling terrible, but they're able to do those things because their dopamine level may be a 60 or 70 as opposed to, a 40 where you see heroin, there's no orange or red. And really the only thing that's going to make this person feel better is the substance. Now, there is some great news here, and that is that most people who have a substance use disorder get better. And healing does take some time, but if people are able to reach 1 year of sobriety, then they're going to be more neurobiologically similar to someone who's never had a substance use disorder than someone who has a substance use disorder. So here we're looking at brain scans comparing cocaine. So you're looking at 10 days of abstinence from cocaine on the second level. And then on the third bottom row, what you're seeing is the brain at 100 days of abstinence, and you're seeing the regeneration of dopamine in the brain, and you're starting to see some recovery. So this person is starting to feel a lot better. And here we have a brain scan looking at methamphetamines. And again, you're seeing the dopamine levels come back to almost indistinguishable levels from the control brain, which is labeled the healthy person here. And, lastly, when we think about epigenetics and looking at gene expression changes over time. So as someone is entering more sustained recovery or longer recovery, their genetics are going to change to sort of help them to stay in recovery. And that means that they'll be able to overcome cravings. The cravings will become less severe, and some of the risk factors that were previously present will start to be a little bit blunted, or at least some of them will. So, I think it's really important to understand the neuroscientific and scientific basis of addiction in order to make smart criminal laws and criminal procedures. And so here I have a resource list if anyone is curious, and I'm happy to share this presentation. We'll put it online. And if you want to reach out to me, then that is my email address. And what I'm going to do next is I'm going to kick this over to Lisa after I give her a little bit of an introduction, and then we're going to have a Q&A. So please put any questions you have in the chat or in the Q&A form, and we're going to try and get to as many questions as possible. We're going to try and leave about 10 to 15 minutes for questions. So I'm going to introduce someone who I think is just fabulous, Lisa Newman-Polk. She is an attorney and a social worker. She worked in the drug courts, the trial courts, and she's also worked as a clinician. She's an attorney, but she also worked as a clinician treating people on probation and parole, as well as the maximum security prison in Massachusetts. And another claim to fame for attorney Newman-Polk is that she also litigated this very famous case, Commonwealth v. Eldred, at the Mass Supreme Court. So I'm going to kick this over to Lisa.
Thank you, Stephanie. What a nice introduction. Right back at you with the compliments. I'm so happy to be here. Let's see if I can share properly. Was interview. Okay, we're getting there. All right. Hopefully we're good. I'm going to jump right in, because what's fun about Stephanie and I presenting together is that we have this shared intersection of both being lawyers, and then she's a psychologist and I'm a social worker. So I'm going to go through some of the DSMs, the Diagnostic and Statistical Manual of Mental Disorders. Here's the little book here, but I'm going to go back. So just so
you know, you have the presenter view on. Either way.
Yeah, no, that's not good. I don't like that. Hold on, everyone. Is that right?
Yes, that's perfect.
Thank you. All right. Well, we're gonna have it's okay. I can't see my stuff, but that's fine. I don't need to. Okay. So before I get to the DSM specifically, broad brushes, this all follows up on what Stephanie was talking about. So intense cravings and a compulsive use that continues despite negative consequences. So that is so important when we're talking about criminal law in particular, which is all about negative consequences. That's the whole name of the game when we're in criminal law. So that becomes a problem for us when it comes to addiction. It's also physical and mental tolerance that drives the person to use the drug of addiction as if life depends upon it. So this is just another way of saying what Stephanie already talked about, which is the brain has changed. Just like desiring to eat, feeling like you're starving and haven't eaten for a week. If somebody put a whole huge plate of food in front of you, it would be incredibly difficult not to eat something. So in terms of the DSM-5, again, the Diagnostic and Statistical Manual of Mental Disorders, this is the 5th edition. Notably, before it used to be in the DSM-4, it was substance abuse and substance dependence. We do not use that term anymore. Substance use disorder. It's a spectrum, and it also gets rid of that nasty word abuse, which is stigmatizing, and research shows it ends up having a bad influence on the listener and often the speaker. So I'm gonna be rushing, and I apologize. We can go back to anything that you need, but some of this is just kind of wanting to flash at you important points to think about deeper. So 483 of the DSM, what is substance use disorder? Cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continues using the substance despite significant substance-related problems. Another version of what I just said. So again, another point on that page 483, it's a change in brain circuits, just like we saw before. And they talk about repeated relapses being the norm. So this is the Bible of mental disorders. If you're a lawyer or anybody, I recommend that everybody have a copy on hand. In terms of how it's laid out in the DSM-5, all of these substances basically are laid out under the full umbrella of substance use disorder, but it's every bit of the next criteria I'm going to show you would be under, for example, opioid use disorder. It would be the 11 criteria I'm about to show you, alcohol, and so forth, all the way down. And yes, at the bottom, you can see caffeine use disorder. You might want to think about your own issues if you're a major coffee drinker. So in terms of the 11 criteria, let's start with 1, substance taken in larger amounts over a longer period than was intended. Persistent desire or unsuccessful efforts to cut down or control use. A great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effect. Now, I want to pause on this when it comes to the criminal law, because of criminalization, people spend a lot more time and a lot more dangerous time on this number 3 here. 4, craving or a strong desire or urge to use. 5, recurrent use resulting in failure to fill major role obligations at work, school, or home. 6, continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by effects of opioids. So again, this of course can apply to the social life, but again, we think about what criminal sanctions are for people. Again, it's persistent and recurrent despite whatever issues are being had in court. Important social, occupational, recreational activities are given up or reduced because of use. Recurrent use in situations in which it is physically hazardous. Continued use despite knowledge of having a persistent or recurrent physical or physiological problem that is likely to have been caused or exacerbated by the substance. So this is where I think courts and sometimes prosecutors and probation or parole officers, I think often very well-meaning, I've actually had prosecutors say to me, I don't understand why they keep doing this. Tolerance is developed. That's some of what Stephanie was talking about with those brain scans. And then finally, withdrawal, which is a concept we've been talking about. So when it comes to DSM and diagnosing a person, you can see at the bottom here, someone who has a mild substance use disorder, according to the DSM, has 2 to 3 of these symptoms. Moderate would be 4 to 5, and severe would be 6 or more. Candidly, most of the people that I am seeing in the court setting are on that severe end of the spectrum. Just want to note the 2016 Surgeon General report. This is the very first and only massive report of its kind. It was a really big deal that the Surgeon General decided to put out a report because it really solidified that addiction, substance use disorder is a medical problem and needs to be recognized that way. So their kind of main title here is Scientific Breakthroughs Have Revolutionized Our Understanding of Substance Use Disorders. And what I've been advocating for a long time, and I know Stephanie here agrees, and I believe the people at Petrie-Flom and CLBB, is that we need to get those, the understanding of the scientific breakthroughs to connect with our laws. So this is just a flashpoint to show you Surgeon General, AMA, ASAM, American Psychiatric Association, World Health Organization. Well, I put Mass Department of Public Health, but perhaps your own state public health. They all agree about essentially that substance use disorder is what we've just been talking about. So that's just important because there's real consensus. If you hear banging in my house, I apologize. There's some construction going on. All right, this is just a different image of what Stephanie was talking about earlier. And I just feel we have to emphasize this as much as possible. There are risk factors. This is not just about people. This is not, I shouldn't say just about, it is not about people being bad. Okay, so early use is a real problem. As Stephanie noted, trauma, I highlight it in yellow because it is the underlying factor with pretty much everybody I work with. Often, I mean, I can assume that genetics are a factor for a lot of people because you can see it in family systems, but sometimes that's influenced, of course, by the environment of the home, social risk factors in the culture of the community, the home, friends, school, etc. And then other mental disorders, for example, ADHD, depression, anxiety, these often go hand in hand with substance use disorder. And I feel like it's just so important to highlight how harmed, especially the people who end up in the criminal legal system usually have been, because there's often poverty intersecting with trauma, intersecting with systemic racism, institutional racism, or bias when it comes to people in poverty not getting the same support in life, and drugs become a way of healing. So I just want to talk about picking up on something Stephanie talked about, but that broken dopamine system, as she noted, there's help for it. And some of the ways that we can help that dopamine system repair. And candidly, I took this from Dr. Ruth Cody in Western Massachusetts. She's amazing. And I love how she put these ideas together. Positive relationships. So restoring relationships, falling in love, or having a pet. And why would that be? Because that can set off some dopamine in your brain, and trying to get it starting to naturally occur on its own. Exercise, that also can make us feel good. Maybe not while you're doing it, but certainly afterwards. And there is sustained mental health and physical benefits, obviously, of exercise. Mental health treatment. So I'll get into that a little bit more in another slide. Medications. So we're talking with alcohol. This could be naltrexone or antabuse, and in the opioid world, methadone, buprenorphine, otherwise known as Suboxone, or naltrexone, often referred to as the Vivitrol shots. So constructive activities, things like going to work, going to school. a sense of purpose, which can connect to that constructive activities or positive relationships. It's being invested in your community or cause or your family, feeling like you really are making something. You'll notice a lot of people in recovery end up getting really into the recovery movement or wanting to give back and sponsoring someone, because why? It makes us feel good to feel like we're helping others and that we can make meaning out of things that have been so hard in our lives. So accountability, I'm not talking about the criminal legal system accountability, but there is that step in AA, the fourth step, about really doing an inventory of yourself, and taking accountability for things that you may have done wrong and want to apologize to people for. Self-respect is so important. I mean, people often are just suffering from lack of self-respect, and one might say somewhat of suicidal ideation. I just don't care what happens to me. And the opposite, obviously, is having that self-respect. And then finally, of course, growing into an adult brain, which I know the Center for Law, Brain, and Behavior has done a whole bunch of work on, is so critical. In terms of components of comprehensive addiction treatment, I talked about mental health treatment in that last slide. So that's things like individual counseling. There are evidence-based therapies, CBT, MET, which is motivational enhancement therapy, sometimes called it motivational interviewing, DBT, which is dialectical behavioral therapy, EMDR, and ACT. And medications for addiction treatment, now often called, I didn't update my slide, I apologize, but this is a more all-encompassing slide. Stephanie was pointing out to me yesterday, of course, that MOUD, which is commonly the term today for Suboxone, methadone, and Vivitrol, that's medications for opioid use disorder, but medications for addiction treatment would encompass also those medications for alcohol. Unfortunately, we don't have breakthroughs yet for medications for so many of the other addictions. One thing about MAT, it used to be termed medication-assisted treatment, and that's a disfavored term because of it's not just assistance to treatment, it actually is treatment. All right, so case management, of course, we've got people who, if you're homeless, unemployed, and co-occurring disorders, we got to get some of these baseline things in order before the treatment can really get underway. Mutual peer support. I mean, this has been proven over and over again. AA or NA might not be for everybody, but it's for a lot of people. And Smart Recovery doesn't have the same religious component, but recovery coaches, people who have been there, been through the experience of addiction and recovery, and are helping people along. In Massachusetts, at Mass General Brigham, for example, and I believe Boston Medical Center as well, they're really big on having recovery coaches be an active part of that full treatment team. And then there are also family therapy, if there are a lot of issues to go through, which often there are when it comes to addiction. So this is just to highlight recovery is not one size fits all. So if I go back to this slide here, it's not like you need all of these things. I want to be clear. You don't need all the colors of the rainbow. It'd be amazing if you do have all of them, but people are going to have some configuration of that in their pie chart, and some area might be bigger than others. But it's so important to be focused on that. Shame is a huge driver of ongoing substance use disorder. And I highlight this because now I want to get into what we do when it comes to the criminal legal system when it's at its most severe, which is locking people away in isolation with the people that have also been termed bad. And what I think is so profound about looking at an image like this is that when you think about the image with all those colors of the rainbow and all the things it takes to get better, this is the exact opposite of all of it. Now, that's not to say that some of my clients who've been in prison don't find ways to, of course, find purpose, accountability, sometimes good therapy. In some places, there is some medication, but it's really, really, really challenging to get that in this kind of an environment. Not to mention that I can only speak for Massachusetts specifically, but I'm aware from talking to colleagues across the country that drugs or misusing of certain drugs on the illicit market are just so common inside. And are very confined and have nowhere else to go, it's incredibly difficult to stay away from triggers. There's a mantra of people, places, and things when it comes to recovery, staying away from people, places, and things that trigger you. But if you're in prison, very, very difficult to, often impossible to do that. Just to know, this is Walpole in Massachusetts, actually just closed down, but kind of the infamous Walpole image of the prison system. So when I was thinking about advocacy, these are the main points I started thinking about. I had been an addiction therapist, and let me go back so everybody's not distracted by that screen. As an addiction therapist, I'd been a lawyer first, and I'd done a lot of trial court work as a public defender where my clients would be put on probation and told to be drug-free. And then if they violated, they were threatened that they were going to go back to jail. And oftentimes they did go back to jail. And when I went into social work, I went and did my master's and focused my training and practice on addiction and specifically people in the criminal legal system. So I had people I'd been working with before, but from a different angle. It really, really struck me how much what we were doing to people did not make any sense. So after working in the maximum security prison in Massachusetts, Susan Baranowski, I decided to go back to law, and I ended up in the drug courts and back in the trial courts as well. And I really started to go mentally bananas when I was in court and seeing over and over again clients be ordered to be drug-free, them hiding if they relapsed, because when I'd been a clinician, I would see how people would try to avoid going to treatment when they realized that they could end up going to jail, because the deal often is you get ordered to be in treatment to do drug testing and remain drug-free. And if a person tests positive, the provider has to share those results with the court. And so I'm a person who was big on transparency, straightforwardness, just being direct, being honest. And I really could not stand how much game playing was going on. I wasn't violating any ethics by any means, but I could know things that were happening to my clients that I couldn't share with the court. And all of it just seemed incredibly dysfunctional. And so these are the things that I started to really think about when I crafted my argument for the Eldred case, which is addiction is a medical condition. It's not a moral failing. Addiction requires treatment, not incarceration. Relapse is a common symptom of substance use disorder, and punishing people for relapse disrupts treatment. So these are the main principles I was thinking about and trying to figure out how to bring into a case when I started doing research. So I don't know if you can see this full screen. Whoops, excuse me. The way my screen's set up, it's cut off a little bit. But I brought this case that went to the Supreme Judicial Court in 2018. And the question we posed to the court was, well, what we argued is that it's unconstitutional to order a defendant who suffers from substance use disorder to be drug-free while on probation and to impose criminal sanctions for drug use when continued use of a substance despite negative consequences is a symptom of the disorder. So I can't really get into the weeds of this case. There's a lot, if you Google online, multiple publications, including the New York Times, wrote about it. One thing I do want to say about Julie Eldred, my client who's been so gracious in being the poster person for this cause, is that there's a misconception that she ultimately got better from being jailed, and then ultimately the judge released her to, after jail, released her to a program as long as I found it for her. And from the court's perspective and the probation officer's perspective, when she was on probation conditions and then tested positive, mind you, she'd been in treatment for just 1 week, okay? And she'd been honest with her doctor about relapsing, and she was doing an intensive outpatient program. When she had that drug use 10 days into probation and tested positive, from their perspective, they were saving her life by putting her in jail in order to then get her into a residential program. From my perspective, and I know was supported by all the major medical organizations who supported the case, was that in fact was doing harm because she was already in treatment. and was being ripped out of treatment, which sends a terrible message that she should never be forthcoming about relapse. And also, it was a judgment that her doctors and providers didn't know what they were doing, and that the judge was saying, oh, I know she needs residential, when in fact she had a very safe place to live. She had wonderful parents in a high functioning situation, which was rather unusual. They were away that weekend, but nonetheless, she had a boyfriend, a fiance who she's now married to, who was there in the court. And I, despite all my experience, really was surprised when the judge locked her up. I was like, what are we doing? She's been in treatment for about a week, and she's been on probation 10 days. And it was very damaging to her. She's talked a lot about this. And she didn't go to jail for nearly the amount of time as other people. We were able to get her out in a matter of some weeks, but that's damaging enough. We're talking about being strip searched, told to bend over, dehumanized. And the message is, because of the relapse, you are a bad person. It's not healthy. And so one just story about Julie is that when she got out to the treatment program, she'd now been taken off of her Suboxone. Now they have buprenorphine in that prison, but at the time they didn't in 2016 when she went in, and they ripped her off Suboxone. So she goes on a residential program, and when she relapsed in the program didn't know she relapsed, and so she freaked out and was telling her parents, telling her fiance, telling me, and she ultimately secretly went back to her medical doctor. And he put her back on Suboxone. But what was really crazy and dysfunctional is that the treatment program she was in had no idea she was on Suboxone. She was taking with a prescription, but taking it against the rules of the program because they didn't know. Bottom line is this: Julie felt like once she got off of probation and out from under it, her recovery really began, and she's been doing fabulously today. And I'll note that she'd been in recovery before, but as Stephanie talked about, it's not a one-time fix for most people. So I am mindful of the time, and I want to skip through some of this quickly. Needless to say, I made a federal argument. I also made a state argument. If you're from another state and you might want to bring a case like this, please talk to me, because I'll get into in a second. I think the court got it wrong here, and that we could see we lost, got it wrong. But I think these are the things that should be argued in other places, because I really think this is the legally and scientifically correct way of looking at this in court. Relapse is a symptom of SUD. It can't be put into remission or cured simply by drug-free orders. It's both the legally correct position and good court policy to not just not jail people. This is very, very, very important. The threat of incarceration is really damaging. So what I'm talking about is not ordering people to be drug-free, ordering people to abide by laws, do community service, go to school, whatever it is, go to treatment, but ordering people to be what I think is essentially cured or remission of an addiction is just blankly not something that can be done. So you cannot order a medical outcome. So again, Eldred lost. It's very sad, to say the least, to put it mildly. I show this because it's fun, and also to say that what I really was trying to do, and I'm still trying to do, is stop the cat and mouse game that we have in court, where people who are struggling with addiction are trying to cover up positive drug screens, trying to cover up that they relapse, and aren't able to just be like, this is where I am, okay? And the other thing I'll point out is that most people, for example, who are in treatment and really working at it, well, let me put the opposite way. People who go to treatment, then go AWOL from treatment, often they're violating other parts of probation. You know, there are other issues they're not attending to. My bottom line is, as much as I don't like mandated treatment, if we're talking about the court system, mandating treatment is something that's doable, but we can't mandate the outcome. All right. For those, again, in other parts of the state, to the extent that you're interested in bringing this argument, please understand that footnote 6 of the Eldred decision makes clear that the real issue they denied us on is that they said the science was not settled. And what we're really clear about today is that the science very much is settled in terms of some of the basics that I was getting at when it comes to the Eldred argument. So again, frustrating, very frustrating, because I said, hey, the Surgeon General supports what I'm saying. That is consensus science. So when their decision said there was no consensus science, I was kind of batty about it. Just a little info. I worked on a bill here that we're really hoping to get through this session, an act relative to treatment on imprisonment. And this would prohibit courts from incarcerating people for relapse if they're engaged in treatment. So the difference between that and the Eldred case is that people do have to be in treatment. All right, so the last few minutes here, because I know I have to wrap up no later than 1:20. I just want to highlight some other aspects of our law, which is really getting at the criminalization of drugs to begin with, and our law enforcement way of dealing with drugs. I think it's clear that from as far back as we can go in humankind, people have long sought mind-altering substances, and of course they have, because life is super challenging and can be just painfully, just horribly difficult for a lot of people. And so, of course, wanting relief is important. And that's why I think the just say no aspect of going after drug use is just not effective, because it's law enforcement coming in and teaching children. I'm a child of the 80s, so I remember police officers coming in, and it was really taught from a you are bad perspective, opposed to, hey, let's look at the holistic thing. Why might people want to use drugs? What's going on when you do that? Here are the risks. Here are the reasons that you would want to avoid something. Maybe wait till you're older. Be aware that something can be addictive. We'll see what happens. I have an 11-year-old, but she's been learning about drugs since she was probably about three years old, just because of the nature of my work. So this has already gone through some. I want to get to, just let me put it here. Sentencing Reform Act of 1984. You can see how incarceration of Americans just went up and up and up and up as a result of that. So very important, over sentencing, this criminalization mindset about substances. So harm reduction, to quickly go through, I highly recommend, if you're interested in this, going to www.harmreduction.org. But basic concepts of harm reduction: safer drug consumption services, understanding that drug use is complex, it's multifaceted, and there's a continuum of behaviors from severe use to total abstinence, and it acknowledges that some ways of using drugs are clearly safer than other ways. Establishes quality of individual and community life and well-being. It's not necessarily a cessation of all drugs. The criteria for successful interventions and policies. I apologize for being tongue-tied. So harm reduction, this is so important. It calls for a non-judgmental, again, courts are filled with judges, calls for a non-judgmental, non-coercive provision of services and resources for people who use and in the communities. And the four more, it does not attempt to minimize or ignore the real and tragic harm and danger that can come from illicit drug use, but ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. And it affirms that people who use drugs should be the primary agents of reducing that harm of their drug use. It really seeks to empower people who are using drugs, which is very important in terms of how to get better. And so importantly, this last one here, recognizing the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequities affect both people's vulnerability and their capacity for effectively dealing with drug-related harm. So this is not to say it's really easier for one person over another, but we have to recognize that a person who has resources and privilege is going to have a lot more help in that recovery journey than somebody who is suffering from all the other things listed. So just really quickly, supervised consumption services, also known as safe consumption sites. These are designated sites where people can use pre-obtained drugs under the safety and support of trained personnel. So means they're not providing the drug, meaning the site isn't providing the drugs. People have already gotten it. So that can be a little tricky because they already have to get it legally. And these have been put across the country. And then one somewhat novel but old idea that established in Switzerland is the heroin, it says assisted treatment, but it's the idea that people take heroin, that in those sites, it is provided by the medical supervisors in the facilities so that they're providing a clean synthetic grade heroin so that people know what they are taking, which is so critical. Most of the deaths that we are having today is because people do not know what they're buying. They just don't know what they're buying. And so by no means am I saying this is simple, but I do think we need to be looking at regulation of drugs rather than criminalization and prohibition. So as a final thought, for work to punish people for addiction and relapse, we'd have a cured nation. So let me stop the screen share and I will toss it back to Stephanie.
Thank you, Lisa. That was fabulous. And what I think is really interesting about the treatment that involves administration of legal heroin is that people tend to do much better. So instead of spending all day, every day thinking about where they're going to get their heroin, they know when they're going to get their heroin. And so they're able to maintain their jobs and work and families. And over time, they tend to stabilize and no longer need the heroin. So we have several questions. I'm going to start. There was one question about how courts react to the scientific information that was shared and whether they're receptive to this. And I would say I do a lot of trainings of judges, both here and nationally and also internationally on addiction. And I find them to be very receptive. And one thing that I seem to get the most sort of movement with is when I show brain scans involving dopamine and how addiction changes the brain, because I think there is this really culturally embedded narrative that addiction is a moral failure, it's a choice. But when we show the brain and fetal brain scans and things like that, that show the low dopamine, that I found courts more receptive to, and they kind of a light bulb goes off. But that's through judicial training. I think in the courts, when you're advocating as a legal advocate or an attorney, it can be much more difficult to make those arguments as opposed to in the neutral judicial education realm. And Lisa, do you want to add to that?
Yes, I mean, I can't speak for training judges widely from that perspective, but on the ground as an attorney, it's been incredibly frustrating. I've been moved into the parole world, lifetime sentences seeking parole, and so right now my audience has been the parole board, and it's a constant state of trying to educate. And I think when you're in a conference, it can be a little bit easier. But on the ground, when they're looking at somebody, I find that in general, judges still want that tool, as it's been described to me, to lock people up. And again, I want to emphasize how much the threat of incarceration, not just the incarceration, is such a public safety problem.
Okay, we have a number of questions. I'm going to do some kind of in rapid fire. So there's a question about the brain's ability to bounce back. And if a person has used heavily for years, is it still possible for their brain to reach near normal dopamine levels after a year plus of recovery? And yes, there may be other structural changes in the brain, but dopamine does tend to regenerate. And there's another question about mandated treatment. And as my colleague and friend Robert Kinshirf just texted to me about mandated treatment, a lot of the outcomes around mandated treatment are weighted by if the person has a quality relationship with the provider, if they're using evidence-based programs or treatments, and also the duration of treatment. And I have plenty of people who come to me initially and they don't really want to be there, but through building a relationship, I mean, they're so alienated by the system because people are so judgmental and unkind. And when they tell people that they had a relapse, people are really mean to them. And really the first thing we should be telling people when they have a relapse after a prolonged length of sobriety is, I'm so sorry that happened. How can I support you right now? Go ahead.
Add to that the legislation, for example, that has been supported by CLBB, because treatment is already a condition of release for all the people who are ordered to be drug-free. For most of the people ordered to be drug-free anyway, we very specifically in the legislation have crafted it to allow flexibility so that people, if they're not feeling a good experience in one treatment, they can transition to another. And we really tried to put in a large scope of possibilities for treatment.
That's a really good point, because what I see in court orders is the default that people go to AA or NA. And for some people, they got sober and entered into sustained recovery through through those support groups. Others, they hate it, or they have social anxiety, or they don't believe in God, and it's actually increasing the risk of having prolonged substance use disorder. So really giving people agency over what they do. I mean, I think, at some point they have to do something, but it could be mindfulness-based recovery. It could be women in recovery. Smart recovery is evidence-based. So really giving people agency. Lisa, there's a question about courts being more willing to accept arguments for Eighth Amendment violations in the context of some withdrawal. So if people are experiencing really severe withdrawal symptoms, alternatively, if a defendant needs to engage in substance use to avoid lethal withdrawal symptoms but can't afford treatment, is there a potential necessity defense to probation violation? Sort of what defenses have you found to have any effect in courts?
What defenses are working in court?
Yeah, in terms of to sort of explain or mitigate the fallout from use.
I mean, I think it always just depends on who is in front of you, who's the probation officer, who is the judge. I think that drawing on the science, for example, works really well with some people. When I was in the trial courts in particular, I was really going out of my way to develop a good rapport with a lot of the younger prosecutors. I just want to highlight, I think we are in a generational shift here. And it was an interesting experience to find so many young prosecutors really open to what I was talking about and actually agree to not put drug-free orders on people. That happened multiple times, actually. Less common for sure with the older guard. And in terms of defenses, it's kind of too complicated, I think, to get into in the last 3 minutes, but it's a range of trying to explain where somebody is. They're in treatment. This is what happened to them, but locking them up isn't going to work. But I'd have to be kind of in a more specific conversation to detail it.
Yeah, and I think, using different opportunities as a time to educate people. I mean, there's a question here about what recommendations can be given to court practitioners who are responding to a hardline judge who can't see beyond drug use relapse as a new law violation, which violates probation or pretrial conditions. I find that really challenging. And sometimes I'm talking to probation officers, and Lisa and I were just talking about this, and I was talking to a probation officer. I had a client who, after I think 4 months of non-use, had a single incident slip up, and the probation officer said he needed to go to detox. Okay, so no detox in the state would accept someone because they're not addicted to the substance that they've used once, and there's no need for that. But this probation officer also said, I don't believe that relapse is part of recovery. And so, with this probation officer, who I've been talking to for many months, part of it is building a relationship with him so he feels more sort of open to some of the science and different ways of looking at this issue. And I think we have to keep referring to the science, and the American Medical Association, the American Society for Addiction Medicine, all of these professional organizations. Lisa, do you want to add to that?
I do. One thing I want to really encourage people in other states to do, because this has worked really well here for me, obviously I have some comfort because I was a treatment provider. And so that gives me some confidence to talk about this. But if you start talking to me about DNA in cases and the like, I start getting, oh my God, I don't know what I'm doing. I don't know what I'm talking about. And so one of the things that I've done is developed really great relationships with I would say the top medical providers in our state who are specializing in addiction treatment. And so presidents of MASAM, which is Massachusetts Society of Addiction Medicine, and they have been helping me. In fact, I have them all doing a letter for me for a case tomorrow, and it's education. Point is, it's education, educating the people who are in power. And so if you are in a different state, for example, defense bar needs to build alliances, in my opinion, with that clinical community. So go to your local version of ASAM or Medical Society, and figure out the people who are aligned with you, because most likely they are frustrated with what courts are doing to their clients too, their patients too.
So on that note, Lisa, I love the call for more education, which is a sort of a tenet of Petrie-Flom and the Center for Law, Brain, and Behavior. I think this has been a really rich discussion. And if you want to email Lisa or me about anything that we talked about today, you're more than welcome. We're going to post our slides. And Lisa, thank you so much for being here for this really rich discussion. And thank you to the audience for all of these really great questions.
Thank you.